Welcome to the Insurance Committee. I'm Nancy Urick, and I will be the chairperson. Calling the meeting to order. There aren't currently any citizen comments. And the motion to approve remote attendance will not be needed because there currently aren't any. Can I have a motion to approve the minutes from the previous meeting? Doug and James, thank you. Are there any questions or comments? Not anything yet? No, okay. The hearing none above will favor said motion, and all opposed say nay. No. Okay, yep, say aye, okay.
You need to ask everybody though.
Did,
You need to ask everybody to approve.
yes. Do we agree to approve the minutes from the previous meeting? Okay, thank you. Any opposed? Okay, motion carries. Okay. Assume we're not done approving the bills yet, so we'll get back to that one. And then Beth from the Horton Group will present the insurance information. Beth, please present your presentation.
Good morning, everybody. Thank you for your time. It's good to see you. It's good to see you. Do I need your shirt on?
Yeah, now you do.
Good morning. It's good to be here with some warmer weather, finally. It's awesome outside. So we have a little bit of a redesign to our normal report. You probably saw it in your emails with the February data. There's also a redesign on the Health Joy report, so I'll talk about that a little bit when we get there, and it's still a little bit of a work in progress on that report. It's not exactly the same metrics I was looking to include that we had included previously, so I'll work those kinks out. We are still pretty early in the year, so we've got data today through March to review, so the first quarter of plan performance. And it's been an interesting start to the year. You may have heard news within the last week of United Healthcare's situation. They released information on earnings, and their stock plummeted last week in one day over 20 points. And that's something similar we're hearing from all the carriers in the market right now. They're struggling to appropriately price the risk that's in the market, and it's something you've heard us talk about in these meetings over and over, probably for the last year, that there's a big concern in the insurance company market with overall risk, not necessarily for your population and plan, but just in general with things like pharmacy, gene therapy, cancer claims. Now we're seeing $1 million claims regularly. And sometimes 2 and 3 million, but those pharmacy claims like the gene therapy drugs could be a $2 or $3 million claim on a plan, but it's a cure. So there's a lot of volatility right now in the market because they're trying to understand how to price this. And when United Healthcare came out with their earnings and missing the mark on that risk component, it made a lot of news. And Blue Cross is in a similar position. They're just a nonprofit, so they are not publicizing this risk and earnings and things like that because they're not publicly traded. But they're in the same spot, and we're seeing with our renewals thus far this year, and we're currently working on July and soon August renewals, they're coming out very high. 20 to 30% range to start on fully insured groups. On average, though, they're trying to get them at the end of the day somewhere in the early to mid-teens. I haven't personally, and I know my colleagues, we haven't had a lot of groups in the single digits, which has been unusual in the past number of years. So there's a lot happening right now in the market. Now, your plan is partially self-insured. You have a specific deductible, so you are on the hook for your claims up until that deductible. So for the most part, you're your own insurance company. Other than those large claim situations where you have reinsurance protection. The reinsurance market is also volatile, but in your pricing, the reinsurance makes up about 15 to 20% of your total plan costs. So not a lot. So if in my presentation, when we talk about large claims and the risk to reinsure those large claims, we're seeing reinsurance costs and pooling costs going up 30 to 40% on plans. But again, remember, it's just a small piece of your overall cost. The majority of what you pay are your claims and things we can do here to help control claims. And we'll talk about that a little bit more detail with the HealthJoy piece too. The market is looking for ways to do things more with less. So AI is going to be a big player in that. Virtual care, home health care is going to be expanding further and further. They're even talking about pediatric home health care, which could be an interesting, advancement or change. But virtual care has been upon us for 5 years now. The pandemic really thrust that forward. So they're going to continue to leverage things like that to try to do it that more with less. In fact, Advocate is currently testing a pilot with AI with their nurses. They have such a struggle to find nurses. So they're using AI to support the nurse administratively. So we'll see how that all kind of transpires, and hopefully there's a good use for something like that to give them a little bit more of a balance and a quality of life, because there's a lot of paperwork behind those patient visits that they have. And if AI can help listen in on those visits and take the notes and log the notes, that would give them a lot ability to treat the patient more than doing the administrative tasks of treating the patient. So more to come. There's a lot of exciting things happening. If we want to flip to page 2, so it's a new design, and the first page 2, looks at how the plan's performing versus expected. We did have a very hot start to the year. When I looked at January data based on expected, and it's really, that's 1 month, so it's not anything to get too crazy about, you ran at 123% of expected. So right away we started out hot, and it had a lot to do with large claims. Now that has come down nicely in February and in March. So it's good that we sort of waited to look at a quarter's worth of data, because now we're running at 103.6%. So there were early large claims that happened that just caused the number to be out of whack, because you're on point for those large claims until $150,000 is paid. Once the $150,000 is satisfied, then the reinsurance kicks in and pays any claim, any amount above that for the rest of the year. So you can see the expected number in the first bullet point, and then I just made a circle around the per capita cost. We started at a $26,000 per capita in January, and we're down to 23.9 at this point in the year. So let's hope this keeps, the large claims are behind us. I think some of them were repeat large claimants from last year that just were bridging plan years and had some residual claims to kind of finish out. So page 3 kind of hones in on the large claims over on the left-hand side. So we're looking at claims that in that first box, there are 4 of them, over half of your spec deductible. So any claims over $75,000. There were 4 in the most recent time period in 2025 in the first 3 months, and there were 2 last year in the same time period. Employer responsibility on those claims was $486,000 so far this year. Last year it was $247,000, so higher by $238,000. The carrier responsibility at the moment is trending lower than last year, which is not a bad thing, but I think as these large claimants now are in their pocketbooks, we're going to see that kind of catch pace with last year. The box off to the right looks at actual costs. So the top box says 25.8%. spend is higher by 25.8% than 2024, or $536,000. Now, when you look at the second box, we're looking at claims over $10,000. So any claimants that had more than $10,000 in expenses so far this year, and then between 10 and 50, and then over 50,000. So when you look at those two categories, our spend between 10 and 50,000 is 50% higher in 25 than it was in 24 in the first quarter, or 357,000. And then for claimants over 50,000, we are 12.1% higher, or about $90,000 higher. So when you add the two together, on those claimants over $10,000, we're $447,000 higher. So that's what's making up the most of the 25% higher year over year. I think as the year goes on, this will start to normalize. It is early, just being that we have 1 quarter's worth of data. When we meet our next meeting is in June. When we meet in June, we'll have 5 months of data. And at that point, we'll be able to put together some more forecasts on the renewal and stuff, and give you a better indication with a little bit more data on how the plan is looking this year. Any questions? Sure.
Back up just a little bit when you talked about the AI being used now by RNs. How about malpractice in relationship to that? Do we need to have a certain degree of coverage on that type of process so that we're?
No, so it's the providers using it,
Okay.
and to a certain extent, the vendors that you have contracts with, so they would have that sort of protection on that. You wouldn't need to have it because the
Okay.
county is not, engaging the service.
So what if they don't have it? Then where are we at? Does that
it's-
come to us?
Yeah, you're not liable for that. This
Okay.
is their business practice.
Okay, all right.
Yeah,
Thank
and
you.
there has been some noise in the market with AI because some of the carriers were using it based on algorithms on how to pay claims, and they made the news for denying too many claims. And with everything that happened at the end of last year with, the CEO at United Healthcare, there's just a lot of mistrust and distrust. And I mean, I can fully understand why, because it feels very profits oriented and generated and very, let's deny and let people try to fight for it. Now that said, the carriers really don't deny that many claims. I think in that scenario, an issue with the algorithm was found out. It was not intentional, or at least I hope it wasn't, and then fixed moving forward. So there is scrutiny in that area. I think that's why maybe AI gets a little bit of a bad rap when it comes to insurance, because that everybody's skeptical. But
Sure.
I'm hoping from a provider standpoint, it gives our lack of access to doctors and nurses, gives them more time to treat more patients. Assuming it all works like it's supposed to.
Thank you.
So page 4 is your enrollment. Not much to talk about there, but your enrollment is basically the same in the 2 time periods. We have 2 fewer employees and 1 fewer member. Again, not a big shift, not a big change. So we have about 437 employees insured under the plan and 863 members. Members includes employees, spouses, and the dependent children. So everybody, the whole family. Slide 5 is pharmacy. So this part of the presentation kind of digs into pharmacy a little bit more. And the first box looks at your generic dispensing rate, which is excellent. It's 91.4%. Your substitution rate is almost 100%. So where possible, the plan requires members to have a generic equivalent. There are certain situations where that can be appealed, and that's where you get that 0.5% leakage. And they probably appealed it due to a really specific situation that doesn't allow them to take the generic. So that part is working great for you. The specialty spend, there was a time, and in the market, this is on groups, this is around 40 to 50% of pharmacy spend. So yours is at 33.5% of pharmacy spend. And there was a time it was much higher. Back in the days when we had your post-65 retiree population on the plan, this was an area of much greater expense. So having that group carved off to the Medicare Advantage program is helping to shift that risk elsewhere, because we're looking at 1.5% of the fills amounting to 33.5% of your pharmacy costs. So if you flip to the next page, you can see what those fills are. I take it back. The specialty fills are on the page 7. So let's jump there since we're on that topic, and then we'll go back to page 6. So yeah, you've got, in this time period here, the 3 months, you've got 45 claimants making up a cost of $117,000 in pharmacy claims, just for a few medications. Autoimmune mainly is on here. Cancer medications also are on here in the specialty category. If you look at page 6 in the pharmacy breakout, this is your top non-specialty medications. And this category has really changed over the last 2 or 3 years. Things that are new on this chart, and we've talked about it in previous meetings, are the GLP-1 medications. The GLP-1 medications are also sometimes known as the weight loss medications. But really on your plan, specifically for weight loss, they are not covered. However, if someone has an underlying condition like type 2 diabetes, they can get these medications. So you're talking the number 2 medication, Mounjaro, Trulicity, Rybelsus. Those are examples of the GLP-1 medications. And those drugs, average costs are between $1,000 and $1,300 a month. So we've been working, Melissa's kind of brought just some feedback to us to say members are asking questions in this area and looking for more support. So we're in the process of reviewing what options are available. You currently have Livongo through Teladoc for hypertension and diabetes management. So we're looking to see if there's an ability to bolt on a weight management support piece to that, and what that would look like, what costs are associated with it, just to see if it really is something that would make sense to add as a solution. Another new app that is coming from Blue Cross that we just learned about, it's starting 7/1 on all fully insured groups, and I'm waiting for pricing on this for my custom groups and my ASO groups, which is what you are. It's called Twin. The app, from what the demo I received, is pretty amazing. It basically, through different lab work and also health risk assessment questionnaires, generates in the app your own twin to say, let's look at you personally, the things going on with your metabolic state, and decide what is it that's going to make a difference for you. Where can we really help you get to your ideal metabolic twin? And then it's going to start giving you, through AI, again, specific things you can do. But it's if somebody's going to get involved with this app, it's going to be some work. They're going to be logging food. They're going to be logging exercise. And they're going to have coaching support. So we'll get more details on that, and we'll see if that makes sense from a cost to benefit standpoint to roll out to the members. And that's really what we want to see the market doing with these GLP-1s. There may come a time that it will make sense for health plans to cover them for weight loss, for other conditions. We're just not there yet because there's no clinical return on investment information available. Right now, it's just cost, and we're not seeing what other benefits the medications are providing. So at the moment, fully insured groups, self-insured groups, the vast majority are not covering them for weight loss, but that over time may change as more data comes. Now with these GLP-1s, they're pretty new to the market, and so they will not have generic options until 2032. That's when patents run out. So we have to deal with these costs for quite a while. Hopefully that maybe legislatively things can be done to change something like this, because it is very frustrating, the cost we pay for these medications versus what you can get them in other countries. So top non-specialty, specialty, definitely an area of a lot of expense for the plan. So things we're continuing to look at and make sure are handled the most efficient way.
Do you expect the cost that we incur for non-specialty drugs and specialty drugs to decrease in proportion to what we're paying now? Because, like you said, it's a fraction of what other countries pay. And I know I've heard that they're studying that. Have you heard anything on that?
No, unfortunately, we don't see where the cost is going to change in the near future. I think they're trying to negotiate it, but in Washington, but on the Medicare side. The frustrating part about that is it's great if you want to control costs on these drugs there or limit costs there, but there's a push effect on the commercial side then, because when providers and drug manufacturers don't make the kind of money they need to on the Medicare population, we tend to see our costs get more expensive on the commercial side of things. So unless that legislation affects across the board, commercial and Medicare, we don't see a cost change happening there. So we have to kind of deal with it. It's a challenging area, and I think there's a lot of scrutiny here. And so hopefully there will be a time where it really gets looked at, because, there's a lot of costs here, and I don't want to get too political with it, but I think it really is something that needs to be looked into, because it's obvious, and there's been a lot of people. I mean, I think even at the end of last year, Bernie Sanders just blowing the horn about how expensive drugs are in the U.S. versus other countries, and what a shame that is. So hopefully that continues to be on the top in Washington, and we see some change. If I didn't hit pharmacy hard enough, slide 8 looks at J-code medications. And we've talked about these for a while with this group and with all of our clients. These medications are actually happening under the medical side of claims, because these are drugs in situations that are administered by a healthcare professional. So they're either done at an office setting, a home setting, or outpatient. The plan has mechanisms built into it to make sure that at the onset of a condition where a drug like this is needed, it maybe first is done in a hospital or at an outpatient facility, but then over time is transitioned to a different site of care, because it's way less expensive to administer these drugs in an office or home setting. And where possible, it's transitioned there. In some cases, it's not possible, depending on the condition someone has. So slide 9 jumps into HealthJoy. This is kind of a boring slide. I tried many different ways to try to get a chart in here, so I'm going to work on that. They changed their reporting on us, so I don't have some of the nice graphics I previously had. But you do have 39% activation in the app, which is good. That's growing. I think we were in the low 30s before, so we are growing. In the first 3 months, the app has provided a total savings of about $12,000, $11,908. Since inception of the app, so starting 2024 is when we rolled it out at the beginning of the year, it has saved the plan $77,000 with redirections of care, pharmacy solutions or alternatives. And that's actually on the next slide. It gives you the different areas people are using the app. So it's 3 categories right now: services, requests, and administration. Services are going to be like helping somebody find care in the network. So maybe somebody comes to the app and says, I need to have an MRI. And the chat function of the app will ask them a bunch of questions. Oh, what's the problem today? What sort of part of your body do you need the MRI? And then they're generating and driving care to the most efficient, low-cost provider within the network when people are using it to seek care. And then the other part of services is the Teladoc general medical consults. So that's, I woke up this morning, I don't feel well. Maybe I have a sinus infection. I know what those are. I know what the symptoms are. I'm going to do a virtual call with a doctor. It's not my normal doctor, but it's a doctor I can get quickly, and they can send medications in for me if it comes to that. So people are using it in those two areas, and that part made up about $7,600 of the savings so far. The request area, there's a lot of things you can do for the request area, but right now people are mostly using that for that RX savings piece, prescription savings. They use in that chat feature and then within the app, if you say, hey, I'm taking this medication, is there a place I can go to get a better deal? They will price things out with GoodRx. They're also using Mark Cuban's pharmacy. In those situations, if people use those options, it's a claim outside of the health plan because they're saying, wow, I can go to GoodRx and pay way less than what I paid underneath the sales plan potentially. Your folks, maybe not as much because you have copays and lower costs, but if they're in your high deductible health plan, your HSA program, all day long people are using the app for things like that to try to leverage a lower cost. And then the admin services, that's going to be like the wallet card, for example. That has, and the chart on slide 11 gives you the number of interactions. So you had 64 wallet card clicks. So the wallet card is basically houses all your ID cards as a member. So if you didn't have the plastic with you, if you've got your smartphone with you, you have your ID card with you. So when you go to the doctor, you could just show them your ID card on the phone. And then there's health plan coverage. So there's different cards within there that talk about how the health plan covers things. And so people are using that within the app. So the bottom charts just look at, the frequency and the amount of people. So benefit questions 2, health card coverage, or health coverage 33, and then 64 wallet views. And then for the service breakdown, you can see the chat feature was used 3 times by different people. Find a care search was used 17 times. So people are going there to find a provider in the network or have somebody give them help with that or direction to where to go. You can message through the app with people. Initially, when you use the chat feature, it's a chat bot that gathers the information, but then it funnels it to a person who does the research. We had a call with HealthJoy just actually yesterday to talk about supporting the HR team on how we can communicate the platform more, how we can boost activation. So we've got some ideas. I think Melissa has a really good handle on the population and how to communicate with the population. And I think your biggest challenge, and I agree with her, is getting it home to the spouses on the plan, because a lot of times those spouses are the ones making the healthcare decision for the family. So do they know this tool is available? One other exciting thing in HealthJoy that I've been getting some training on and hearing about, I feel like I have to sneeze, sorry, is how they're using AI as well. They have a trait distribution piece that gathers information based on what people put into the app, and then it's done through like a risk questionnaire, the ways they're searching things in the app, if they're using pharmacy, medications, or getting medication costs. And it's putting them in different categories where they're making recommendations like mental health, nutritional support, weight support. And this is kind of where some of the side project is coming from, because we're seeing people using the app and needing help in those areas. And so as we see that build, that's going to be another way for us to understand what the population needs. I think that is it for me, unless there are any questions.
You kind of addressed that question, but it looks to me like the usage on health. Oh, sorry, I'm sorry.
I think you kind of addressed it, but I just wanted to talk a little bit more about it because when we look at Healthjoy, we're sort of at a break even, right? What it's
Right.
costing us and what it's saving us.
Right.
And so, and I agree, I think Melissa has a pretty good handle, but do we have a plan at all to try and expand that a little bit more so that we come out in the positive instead of
Right.
just,
Right. Well, I think the ROI,
yeah, it's 1.1.
yeah, but
Yeah.
the 11,009, right, that's, and it was. Yeah, it's just for the first quarter, right. So it is saving you something, but it's not as high as we'd like it to be.
Right, because by the time we pay for Healthjoy, it's pretty much
Right,
even. It's pretty
right.
much even, yeah.
So
So,
that
yes.
was the purpose of our call yesterday
Okay,
too,
uh-huh,
and we've
yeah.
been talking about this all along. How do we get it out there and push it out there more?
Yeah,
There was we really tried with the retiree population, and there just was no traction there. So that was part of this year to say, I think that enrollment needs to come out of this because they're just, we can't get to them and they're not using it, so why pay for it?
oh,
Is that
okay.
fair to say, Melissa?
Yeah,
We're not focusing on the retirees at this
Okay.
point.
That makes
We're just going to
sense.
focus on the actives, and there is enough in the active group. But really, the target, like Beth said in our discussion yesterday, was what tools and resources will Healthjoy be able to give me or suggest? Because we really need to get to the healthcare manager within each household.
Yes,
And e-blasting to work emails only goes so far, or the personal email, because if it's the employee's personal email, but they forget to forward it to the spouse,
right.
then it's still lost. So we talked about what are other ways to do it cost effectively, that we're getting to that healthcare manager in the home. Because I've used it myself a couple random times, and it's very useful. I mean, everybody carries their phone with them 24/7, and everything is on there for your health management purposes with everybody that's under it. So, I mean, it's a tool that if that person, if it's the spouse, if they don't realize it's there, like, you don't have to carry cards anymore. You just take your phones with you and you go, and then the searching part is very useful. And there's messages back to you and inquiries back to you about what you asked for and what the responses were. And they do a lot. There is a lot of research because I didn't have to do anything but tell it what I wanted. And then I wait for responses.
I know,
And then I just go from there. So like, there's a
great
lot
for-
more there that the home manager needs to realize
Yeah.
that they can use. Like it's a very good tool. So figuring out how to get to them, that's what our goal is going to be in the next like 2-month window. I really want to hit it hard and see what we can do.
One thing Healthjoy has told us they're gonna put together is, like a postcard type thing that can be mailed home.
Yeah,
With highlighting it, but also with a QR code that brings them right to downloading the app.
that sounds like a good idea.
It's just getting people to pay attention, read it, understand it, and getting to the right person.
And then I'll probably, well, we're toying around with if I were to do like facility department visits about it and how that could work. So we kind of talked that out a little bit and what could be taken to those meetings to try to encourage people to activate. So that would probably be within the next couple months too. Like I'd like to have as much of that initiated by midsummer so that we can see how it impacts us through the rest of this year. Like I don't want to wait too long to try to get these things done because then we have to wait, we have to see what comes of it. And we
Yes.
really want to see what comes of it in 25.
Okay, okay. That sounds like a good plan. Thank you.
And I think the app is so useful because it's built in all of your coverage. It's like your dental network, your pharmacy formulary, the network for that and for the medical. It's got all of the extra programs, the hypertension and diabetes program. So it knows all that you're offering people, so it can drive them to it more than your employee having to sit and remember Oh yeah, I think I just got diagnosed with prediabetes or diabetes, and I remember they're never going to remember it on their own. So maybe we even look at ways to try to incentivize app application activation once we get past this first step. Was there another question?
What's the wait time for labs on average? Going through HealthJoy, the Find Care bar is by far the greatest one. Is it because the wait time for labs is increasing and people are looking to try to decrease that, or what's the reason?
Like, is your question on like getting blood work labs? Is that what you mean?
Well, that's just one type of lab, blood work lab. And those are fairly quick. But there's
Sure.
other labs that a doctor might prescribe that they go out a month or 2 months to get an appointment.
Yeah, so that's a little bit outside of HealthJoy and just a dynamic of our healthcare system at the moment with trying to get appointments and getting into places. I haven't heard issues with times from that perspective. It's been more of I don't currently have a doctor relationship and I'm trying to establish one, and it might be 6, 8 months before you can actually get in. Or mental health providers. I'm hearing the same sort of thing where people are struggling with that. And that is something the app would help with because there's a lot of virtual options for behavioral health, mental health, and then the Teladoc virtual visits. But yeah, I haven't really heard that labs are taking, even in the extra situations, more time, but if there is something like a situational that you want us to look into, we can.
Are we considered rural here?
I don't think so. I
Compared-
mean, you have a hospital system, you have 2 hospital systems. Yeah, I mean, you're probably more so than if you are near a Chicagoland area, but yeah, I mean, I wouldn't necessarily say you're probably in between. You know what I mean? There was when the app was put in place, there was the concern about the hospital system that went under and closed. And are people going to be able to find access to care? So the committee looked at the app as a way to help people find the care and use, like Melissa was saying, you use them to even make your appointments. So it's almost like it's not just informational as much as it is even a concierge tool to just drive through the mess. And there's we talked about it on yesterday's call, a bill review piece that I don't see a lot of use of the bill review piece on any of my clients, but literally if you think you got a bill in the mail that didn't get paid right, you just have to take a picture of it and send it into HealthJoy, and they'll do all the legwork and come back with you with an answer. Like, yes, it was paid right, or no, it wasn't, and here's what we're going to do next to get it paid right.
That's where I think the education part, like, if I have to physically, like, go with pieces that I can have them take with them to expound on some of these things that they just don't realize.
That's part of it, right?
And also in some, we can talk about this on the side, but I think a lot of people like are so hesitant to do virtual visits. And I'm telling you, I've done them before and they are so easy, and you don't leave your house. You don't have to do anything but be on the smartphone call, and it's taken care of. And I think that delay in care in getting in-person appointments that people are seeing that you just talked about, like you could avoid that a little bit if you were open to the virtual, because I think there are a lot of medical providers that work in the virtual world. Like you could talk to one and they could be 5 states away, but they're concentrated, their specialty is on what your need is. So they're the one that gets the call for your need, and they do the virtual with you. So I believe, would you agree with me?
Yeah.
That they're in the industry and that's what their role is. So you could see them the same day instead of trying to get an in-person appointment with somebody and you have to wait 4 weeks. See what I'm saying? Like if we can get people to understand more that in the virtual world of maybe the first level of a medical inquiry or evaluation, you should be doing it that way to see where you should go. And your wait time will be so much less. But I think some people are hesitant with that.
I do agree with Melissa that I have a school district, for as an example. It's an elementary school district that uses HealthJoy, and their activation rate is like 80%. The majority of that group are female. They're teachers, and they typically studies show the healthcare in the family is typically handled by the female. Not always. In fact, I think I'm more the procrastinator than my husband. I might be the exception to the rule, but or he is really. But so that's a little bit of our uphill battle, is getting it to get home. Thank you. Anything else?
Is there any other
One-
questions?
One last question. Are preventative coverages, like how many times you can have a procedure
Yes.
within a year that would be considered preventative, is that locked in for our contract year, or does that change throughout the year?
So it used to be that preventive was like you could have one visit per year or per 12 months. But with the ACA, that was removed. So back when the ACA required, if you became a non-grandfathered plan, which the vast majority of plans are non-grandfathered, preventive care is covered at 100% without limits. Now, that's not to say a doctor is not going to they're going to follow the different guidelines for preventive services based on your gender and age. So they're going to still follow it and do it probably every 12 months. But the plan is doesn't have any restrictions to how often. But again, they're not going to do a colonoscopy every month, nor would anybody want that. But they'll follow those guidelines. But the plan, technically, because of the way the ACA governs it, cannot put restrictions on it.
Any other questions? Okay, thanks, Beth.
Sure.
Okay. Can I have a motion to accept and place on file these healthcare insurance reports, please? Craig? And Tom, thank you. Are there any questions or comments? Hearing none in favor, said motion passes. Is there any opposing nays? Okay, motion carries. Has everybody had a chance to review the bills then? Yep. Okay. So you're still approving them? Okay. Okay, so we'll go back to the bills. Can I have a motion to approve the bills? James? Yeah, okay, thank you. Kathy? Okay, and let's perform a roll call. Craig?
Aye.
Emmett? Kendra Pottinger?
Aye.
Tom Walsh?
Aye.
James Bailey?
Aye.
Kathy Bright?
Aye.
And Doug Stockley?
Aye.
All right. And we have no executive orders for this presentation. Is there any other questions or concerns about anything? No? Okay. All right. Let's see. Can I have a hearing? Does anybody want to have a motion to adjourn, please? Okay, Craig and Kathy, thank you. All signify by saying aye.
Aye.
Motion passes. And our next meeting is going to be on June 26th, right here at 9:30 in the morning in this room.